summer. All right, just because this is being recorded, please don't mention any PHI, any public or any patient health information in our discussions. Slide, please. This is just a notification that we are recording, but we also collect data for quality improvement and research purposes. Next slide, please. These are just some general reminders that remember to mute your microphone when you're not speaking and unmute yourself when you do speak. If you have any questions, and we do encourage questions, please type them in the chat box. We'll be monitoring the chat, or you can raise your hand. We'll be monitoring that as well, and we'll be able to ask questions, interact with our experts that way. Next slide, please. So I'm happy to introduce Dr. Whitney Jones. Dr. Jones is a gastroenterologist with over 20 years of experience in public health and increasing colorectal cancer screening in underserved areas. He currently chairs the state's Colorectal Cancer Advisory Committee for Kentucky and works as a senior medical director at GRAIL. His current focus is on lead time messaging and promoting on-time screening for high-risk individuals and early diagnosis of those with early onset sporadic colorectal cancer. Today, his talk will be titled "The Changing Face of Colorectal Cancer Using Lead Time Messaging to Achieve On-Time Screening." The presentation will be at 20 minutes, and there'll be a warning notification at 15 minutes. We'll have about 5 minutes for questions. So without further ado, Dr. Jones, you can take it away.
All right, great. Well, thank you. What an honor to be here, particularly to kick off March as Colorectal Cancer Awareness Month. The question of the day to everyone out there is, why did the Colorectal Cancer Coalition choose blue? I have not been able to find that answer myself, so perhaps someone has that. That's not one of your core questions, mind you. That's just a little aside as we go along. So I really, first of all, I appreciate the opportunity, and again, because I do think we are at a real inflection point, and we'll talk about that. But here you can see, a couple of folks up there, Stan Lee, and then our favorite actor from the Avengers, who passed away from colorectal cancer. And I love this picture because we've really spent almost all of our time over the last 30 years, or at least until the last 5 or 6 years, focusing on people like Stan Lee for colorectal cancer. But it turns out we're moving into a generation and a time when colorectal cancer is changing right before our very eyes to begin to affect younger and younger people of all races and all colors. As well, we've also began to understand that our approach of waiting until people reach the average age of screening before we tell them, hey, it's time for colon cancer screening, really doesn't work anymore because of some studies that I'll show you and some statistics. And so, in fact, much like breast cancer became a lifelong educational process for women, the changing epidemiology of breast cancer requires that we begin to change our own messaging strategy to adopt an early age onset colon cancer, identifying high-risk people and screening them on time, as well as giving multiple different messaging opportunities so that people who are of average risk can be screened on time, not sometime afterwards. And so that's really going to be our focus today. But I just love that picture of these two folks, because that really says it all. Next slide, please. So here are my disclosures. I'm a senior medical director at GRAIL, a subsidiary of Illumina. I had been a consultant with Exact Sciences and Myriad Genetics within the last 2 years, and I'm the principal of my own consulting company in Louisville. Next slide, please. So you guys out in the community health centers, as well as those in hospitals, before we start on the talk, you've got really 3 big things going on in colorectal cancer. Number one, we've got to catch up from the COVID, right? We've missed a lot of screenings. We know that. Our databases can teach us who those people are, and using that technology to reach out and bring those folks in, even prioritize them to stool versus non-structural screening is important. Number two, our second big challenge is onboarding the 45 to 49-year-olds. That was almost 10 million people in America. And, it's been a relatively slow uptake to get those 45s in there. But that number wasn't lowered from 50 to 45 for nothing. It was because there's a significant increase in mortality in this group. And then finally, Third is leave no one behind. The real importance of making sure that our efforts to screen people really move across socioeconomic determinants, race, sex, or other issues that we would perceive as barriers. And again, we want to leave no one behind in our screening efforts. So those are take-home messages for your community. Next slide. So this is really the slide that started it all, and I guess it must have been 7 or 8 years ago. Next slide, 2017. Next, can you punch it one more time? And what I want you to notice is at the top, nope, we're going to go back to that other slide. At the top are colorectal incidence rates. And you can see the age at the top. On the far left is 21 to 29, 30 to 39, 40 to 49, and then 50 to 54. And what's interesting is at the inflection point of around 1990, all of those age groups, including age 50 to 54, saw their colorectal cancer incidence rates go from decreasing to increasing. And at the bottom of this slide, you'll in fact see that the ages from 55 and above all had significant decreases. So first of all, what's going on with the 50 to 54s? Why is their rate going up? Because they have access to screening. And then more importantly, of course, what's going on with early age onset colorectal cancer? And we'll get into that in more detail. But I will tell you that as of now, in my understanding of the world's literature, we do not have a single answer for why people under age 50 are getting higher increases of colon cancer. We would suspect it's environmental potentially, maybe it's related to antibiotics uses, something we're eating collectively, glyphosate. The bottom line is I know that there's really a ton of really smart people out there, and I'm unaware of a singular or even a multifactorial cause that does it. However, epidemiologically, we know it's there. So clinically, we need to react to it. Next slide, please. So I live in Kentucky, and when you look at every map of cancer ever shown in the United States, ours is always the darkest, right? Which means we have the highest mortality and one of the highest incidence rates in the nation. And in colorectal cancer, we had ranked #1 in incidence for many years until the last several years, and as well as mortality. So we finally broken out of that. But we're also in the top 3 with regards to under age 50 colorectal cancer. And so at the top, I did a little back of the napkin math here about which states have the highest burdens of colon cancer. And I just basically combined their rank for incidence and their rank for mortality as a rough measure. And again, I think these names are all not unheard of. And here's Georgia down here, our hometown where folks are, number 15. But then when you correlate and you look at this same list for the rank of early age onset colorectal cancer, you'll notice a stark similarity. 8 out of the top 10 cancers, top 10 states, that the highest colon cancer burden also have the highest burden of under age 50 colorectal cancer. And in the second decile, 7 of the top 10 burden states are in that state for under age 50 colorectal cancer. And again, Georgia, you're number 12 in the nation down here as our host folks. So next slide, please. I'm going to make the argument today as we talk about the communication strategy that our overall cancer incidence and mortality rate is going to be drugged down over time by changes in how we address under age 50 colorectal cancer. Not the majority, but mind you, this is a dramatic trend that we've seen going on now for several decades that has no sign of letting up. And so if we're going to address a state's in particular overall mortality and incidence rates, we've got to begin to address not just what we do with asymptomatic normal risk individuals, but how we really address the other 2 or 3 components, which are high-risk individuals based on polyps and familial risk, high-risk individuals based on germline risk, and then importantly also the people who have no risk but develop sporadic early age onset colorectal cancer. That makes up about 60% of those folks. And we've got to get the message out to them to not ignore symptoms. And this is particularly important as a lifelong learning, because first of all, how did you guys all get to this meeting today? Did Kush send you guys an email at 4:00 Eastern time and say it's time for the echo? Or did he contact everybody weeks and months in advance with repetitive emails and messaging to make sure that you guys showed up on time today because it was important to do so? And I wanted to take that example as a way that we need to approach cancer screening generally and colorectal cancer screening specifically as we go through the rest of our talk. Next slide, please. And so this is a simplified version out of a paper that I got the honor of writing with the late Dr. Dennis Anand and Paul Schroy, who's not the late Paul Schroy, by the way. And what we really thought about was, you remember we showed those cancer folks in their 50 to 55s, their cancer rate was still going up. Well, it's because when you tell someone to get screened at age 50, it takes them about 5 years or so to get online with getting their screening performed, because it takes multiple messages to get any kind of sustained behavioral response in adults and children followed. And so it makes sense that we need to structure our messaging and our educational campaigns in a similar way. And so initially we proposed in this paper that we have some type of a risk stratification question with our patients around 35, because we know it's going to take multiple messages to get people screened on time. And those who are high risk based on familial risk generally need multiple messages before they get there. Again, also many people with familial risk need to be screened before age 40. And so again, about 20% of people are at increased risk for colorectal cancer. Messaging people at the average age risk to start the conversation is too late. You're missing all these people unless you've had a specific conversation around them. And then likewise, for people who are average risk, again, you can tell it's been a while since we all went to 45. But again, the need for multiple touches and messages, what we would call lead time messaging well ahead of the event, is really critical for on-time testing. And I would challenge you to find a woman, in her early 20s that already doesn't know about breast health and know when mammograms start and issues around those parts. So next start. And so what we developed was what we called an early messaging package. And again, I think the key thing here is a lot of people saw this as competitive, like, hey, this is different than we're doing. It's really not. It's quite complementary, because one of my take homes for you guys today is 45 is the finish line for messaging around colorectal cancer screening. It's not the starting line, it's the finishing line, because that's the age we want people to get their screening done. And so what was really critical was making sure, in addition to telling people when it's time for their average risk, was developing a process and a program where we're able to identify those 20 or 25% of people who are high risk well in advance of that 40-year-old screening date, so they get a chance to be screened on time with colonoscopy as the preferred modality rather than the average risk. You can hit it one more time, please. But when you really extend this back, you're really looking at a broader, earlier message package. Can you hit that again, please? All right. And so really probably messaging begins even earlier, not necessarily screening, but messaging, really because of several things. Number one, if you want to have a big impact on colorectal cancer outside of screening, we all know a lot of it's related to lifestyle. So getting lifestyle messages in there early about diet, nutrition, smoking, critically important. Number two, another issue that young people need to know about is their family history and risk for genetic syndromes like Lynch syndrome or polyposis syndromes. Those don't help you when you're 50. They help you when you're in your 20s and 30s. So if we're going to try to impact those issues, we have to speak to them at those times. And then finally, this dramatic increase in sporadic under age 50 colorectal cancer that we know leads to delays in presentation and diagnosis. If we're not educating people in their 20s and 30s and even 40s about the importance of this and to recognize those symptoms and to seek out help, as well as educating clinicians, we're missing a great opportunity. And all three of these factors increase the likelihood that we'll get a high-risk person screened on time, and further down the road that they will have heard the message so many times at age 45, it won't be a difficult sell. It'll be, I'm expecting this to happen. You've been telling me for years. Next slide. And so what we've invested in, though, primarily has been this average risk package. And Dr. Hotz can comment afterwards, but for years we focused on this average risk. I think it's what we measured more than anything. Whereas there's a real paucity of data how accurate we are identifying people who are at elevated risk and getting them screened on time, which probably accounts for much more than 20% of our cancer deaths happen in people who are high risk. But if you look at it, we'd almost spent no investment in time in messaging for those elevated risks. So next slide, please. So you can see when you really bring this in, you add these messages, it becomes a more complete package. And I think we begin to address and come to similar areas where cervical and breast cancer screening awareness and compliance are. But again, the next part here, next slide, please, is actually investing in this by putting some money in it. And again, I'm really encouraged at the national roundtable level that we've begun to invest in lead time messaging and on-time screening. But again, if you're not investing in messaging around these three pieces early in your patients' lives, I think we're missing the boat. Next slide. And so in Kentucky, again, we've been pretty on this for almost a decade. Most of our messaging campaigns are directed to people in their 30s and 40s. We figure once they hit 45 or 50, every single person in the world is messaging them. We're working hard to get ahead of that. And so everything you see up here, we can share with any of the organizations around the nation. You can shoot me an email. But these are one of 3 posters that we did that can fit in doctors' offices. We can put your guys' information in here in your local thing, but it basically talks about colon cancer as a journey. And this was made for Appalachia. So again, we tend to use Appalachian backgrounds, mountains, four-wheeling, hot dogs, etc. We have one for urban culture as well, and we have one that's made in Spanish and great, and it's bilingual. And again, we use, I'll say it, we use various forms of Mexican food, various things that are more potentially appropriate for the population that we're trying to reach. But again, these messages over here on the right, we use these on the small screen on the phone, because if you want to reach small people, you're going to have to reach them through where they get their news. And we delivered almost 7 million ads, both in Metro Louisville to urban Black populations, as well as to Appalachian. We saw significant increases in our open rates, referrals to our state program for screening, and again, have maintained our screening rates throughout the pandemic. And I think part of this is making sure that we're messaging people in the way. And again, these were our Appalachian campaigns. We have these for all folks. Next slide. 5 minutes, gotcha. So Kush wanted me to for sure talk about the screening recommendations for everybody. I just wanted to make sure, again, following our theme, we're not going to start with average risk at the bottom. We're going to start with family history. So people who have first-degree relatives with colon cancer adenomas or multiple second-degree relatives, colonoscopy-based screening needs to start at age 40 or 10 years earlier than their affected relative. For those people who have inherited syndromes, versus Lynch or familial polyposis, there are specific guidelines. But again, genetic testing is incredibly inexpensive, $200–300 now versus thousands of dollars in the past. So please make sure you're taking a cancer family history and have some kind of tools that help you with current guidelines, because again, these people may need to start screening in their 20s or even their teens for familial polyposis. And again, there's a link on there about up-to-date recommendations. Certain medical conditions such as inflammatory bowel disease or polyp surveillance. Again, IBD, can have multiple issues. And again, I recommend you go to those guidelines for specific issues every 1 to 3 years, depending on how much is involved. And obviously the same with cancer surveillance. But once you get to average risk, you have lots of choices. Again, we start at age 45. FIT, stool DNA, CT, or optical colonoscopy. Again, all appropriate, all work. The best test is the one that gets done. Next slide. So, but I want to get you ready because, as soon as you think something's static, it's not. And so we are really right now in the molecular and genomic age of medicine. Precision oncology, evolving molecular diagnostic tests based on blood and other samples are really going to completely paint the future of medicine that you guys live in. And so artificial intelligence is coming. It's probably already here in many cases, but I think it's really critical that physicians understand that you don't give up one age for the next age. It just adds on top. It's another layer of protection. And I do see a time when machines and man and women work next to each other and delivering the best care that we can utilize it. So it's extremely important. But again, next slide, understand we're going to have tons of changes coming up, including expanded stool options. There's going to be multiple blood-based options that are coming out. Multi-cancer early detection is a new technology with multiple people in that marketplace. Not only has the capacity to backfill and diagnose an additional 50,000 people for urine and colon cancer, but also to help multiple other cancers in the GI tract and otherwise. And again, expect genome sequencing and AI and algorithms to really cover the entire cancer journey, as you see on the left. And so I recommend everyone out there up your game on genomics, the epigenome, which is critically important, and utilization of molecular diagnostic tests, because this won't stay, at high academic levels forever. The most important part about some of these tests is they are really going to be tools to democratize screening and get screening options out to people who currently don't have that access and don't have those options. Next slide. So as we finish, these are the questions I want you to be asking your practice, your clinic. How can we improve our colorectal cancer screening rates? Do you guys have your baselines? Do you know what your benchmarks are? Do you have your processes? Number two, how can we elevate family cancer history collection and review? I think this is a critical piece if we're going to identify people at the highest risk, and identifying high family history risk at 45 is not what we're looking for. We're needing to identify that well in front of age 35 or 40, and really ideally in the 20s. So, and then finally, how do we build and deliver early messaging, giving colorectal cancer screenings face, right? Talking to people in their 20s or 30s, that wasn't even on the map 20 years ago when I started in public health. Now I think it's going to populate and really fill in that entire journey around colorectal cancer. And finally, I really recommend that everybody put their databases to work, figure out who's at risk, figure out who's been screened utilizing your data-rich environment, your EHR, find ways to communicate to those people who aren't up to date to screening, utilize for average risk, take-it-home stool tests or mass mailings, and generally make the computers work for us for a little while. So I want to thank you guys for the opportunity to present these concepts and ideas. And as I look to the future, this is what colorectal cancer looks like. For me, if we're going to have a war on cancer, we need to have an appropriate motif for that. So I like to get the nutritionist and everybody else way out here, the smoking preventers out here. Don't eat too much bad food. Our next group are these high-risk folks, and we're going to get the genetic counselors to help us identify these Lynch syndromes. And so by the time they've gotten to high-risk screening, they've been at war with our messaging for years now, and they're ready. They're not going to break through our gates. We're going to be able to manage this and continue on with surveillance in the future. So thanks so much, guys. Happy to take questions, and really I'm honored to be part of this event today.
Thank you, Dr. Jones. That was fascinating and really eye-opening. I especially liked, these are things that we think about, but I've never thought about in the terms that you use, that, lead time messaging for on-time screening. That makes it so easy to remember and understand. So thank you for that. That was great. Does anybody have any questions for Dr. Jones? If not, we can move on to our next presentation, and we have some time for questions at the end as well.
I have one question.
Yes, sir.
For Dr. Jones. Dr. Jones, I know this is part of a concerted statewide effort. Can you tell us what you've done for your screening rates in Kentucky? We've always looked down on Kentucky and mountain folks as being behind, but what has happened to your rates?
Right. Well, when we started our efforts in 2003, actually, this week is our 20th year anniversary of my foundation. We were screening about 31% of eligible folks in Kentucky. Last year, our BRFA scores in 2022 were 75% of eligible people.
Wow.
And we've done the math on that. It saves us almost $44 million a year in colon cancer treatment costs. And again, prevents 675 colon cancers annually through polyp removal, and then reduces deaths by 375 due to identification of cancers at earlier stages. And so, we are a model, I think, for state-based issues. And I'd love to come back another day and talk about all of our legislative efforts, because the polyp loophole and follow-up after a positive stool test, we've had those laws in place since 2015. and have been driving and partnering with people across the state. And this isn't my success story. This is the success story of the entire Kentucky team.
But that does give us an idea about an organized statewide approach like we are trying to do in our roundtables can really, move a state forward. And your success has been dramatic. You may not be number one in basketball anymore, but you're on your way to be number one in colon cancer control. Congratulations to you.
Well, appreciate that, Jim. And one thing I would say is a lot of people do roundtables as other modalities. What we found was really effective was a legislatively mandated advisory committee put together, put through statute, where we have representatives of public health, the insurance commission, we have a senator, we have a representative, we have a governor appointee, and then we've got all the non-governmental organizations, the universities, American Cancer Society, everybody's at the table. And we've met every single month since 2008, working collectively on our problems. And so I think the roundtables was sort of how I learned about it from the beginning at the level. But I would say the single biggest piece of legislation that I would put forth for any state to start off with is create an advisory committee to focus like a laser on one issue. And we primarily focus on screening rates. That's our number one issue, because if you believe in screening, that's what we need to be pushing. We don't focus on all the other extraneous pieces.
Okay, thank you.
But thanks for that, Dr. Hotz. Really appreciate it.
That was great. Thank you. And I think we probably will have you come back because that was really fascinating and want to learn even more about y'all's efforts, legislative efforts in Kentucky. So the next presentation or the next item on our agenda is the case presentation. And so we have the evaluation team from the Augusta University Institute of Public and Preventive Healthcare. This is Dr. Ibrahim, Chris Turner, and Dr. Adiambo. Are going to talk about, and they're led by Dr. Islam, who couldn't make it today. They're going to talk to us about how we collect data at our partner clinics. So just as a reminder to those on our call, we have 15 clinics so far that are part of the Georgia Colorectal Cancer Control Program, and we're expanding every day. And so we're actually going to have, I think, 16 and 17 clinics soon, but many of you guys on the call are part of that program. And so evaluation team collects data, and they'll be talking to you about how they do that and to give you a little bit of an insight into the work that they do. I think if we can pull up the slides again. Brenda, do you have the slides? Let's see. They'll come up in a second.
Just give us a few minutes while it loads up. And
Sure.
yes, so we are the GCRCCP evaluation team, and we are at IPPH at Augusta University. And our team comprises of Sama Ibrahim, who is with the slides, and we have Chris Turner, who is waving over there, and myself, Loriano Diambo. And then we also have Dr. Islam. He's not here with us, as Kush mentioned. And so we'll be talking to you about data and how we evaluate the GCRCCP, and particularly what type of data we collect and what the data really tells us. So as we wait for the slides to come up, I would like to thank Dr. Jones for setting us up and letting us know that we need to put the data to work. So let's just wait for us to get to the slides, and we can tell you more about how we are approaching our program, talking about the functions that we have for our GCRCCP, and also moving on into the evaluation questions. Next slide, please. Next slide, please. Thank you. Okay, so these are the functions of GCRCCP evaluation, thinking of us as a team. So the primary one that we do is to collaborate with our partners and stakeholders to make sure that we implement the EBI's, evidence-based interventions, to achieve CRC screening rates of at least 60% in all the participating clinics. Another thing that we did is that we develop an evaluation and performance measurement plan. And this was a requirement by the CDC who are our funders. And we continue to update that plan depending on any changes, major changes we make to the GCRCCP activities. And next, we use some of the information CDC gave us, and we developed and modified data collection tools. And we also provide training on how to use these tools. So right now we have our clinic liaisons and we have our data managers who are well trained. And in the future, we look to train at least one person from the clinics to be able to provide the data that is required. Next, we submit the data. We work closely with clinic liaisons to collect clinic data. So we have at least one clinic liaison for each of the health system. We have Sable Fleming for EGHC, and we have Robbie Amin, who is in AAPHC. And they're the ones who really help us to get this data. And without them, we can't be able to function as the evaluation team. So as an extent, they're an extension of the evaluation team. We consider them part of us. Next, we track and monitor program implementation activities. So depending on what clinic we're enrolling at that time, once we start implementation activities, we make sure that we track and monitor the activities we conduct with them. Next, we submit the required data by CDC. So they require some data from us for baseline and annually after a clinic is enrolled. We look at the data, we work with the liaisons to validate the data that we get. And we work with the CDC evaluation team to maintain data quality. And then we need to look at the data, analyze the data, summarize it for dissemination. And we do this through different modes. We do it through newsletters that we hope that you receive. We have reports, we have presentations, and also working on publications. And then last but not least, we need to assess the success of GCRCCP and identify gaps and areas of improvement so that we can know how the program is doing. So essentially, this is what we do when we talk about evaluation. But really, what is evaluation? When you think about evaluation, it's like a systematic approach. We collect data, we analyze the data, and we summarize that data, and we share it with everyone to make recommendation, and most importantly, use it to make adjustment to the program to improve the processes. So that is how we use some of the functions of the evaluation. Next slide, please. So while we were developing the evaluation and performance plan, we had to come up with evaluation questions. And we have 4 main questions that we answer using the data that we collect. So the first one, which is whether GCRCCP improves screening rates over time. And this is a question that aligns with the CDC evaluation questions. And we collect this data at baseline. We collect it every month to see our trends, and then we collect it annually after clinic is enrolled. The next question has to do with experiences with implementing GCRCCP. And here we're really interested on the barriers and facilitators to implementation of this program, the lessons that were learned, and how the lessons that were learned were used to improve program activities. For example, at the very beginning of the program, we enrolled only 2 clinics as pilot clinics. So we used the information we learned when enrolling them to enroll the next cohort of clinics. So we do this, we have our implementation tracking notes, and we're also planning to have stakeholder interviews that we'll talk about later. The third question has to do with implementation outcomes. And when you think about implementation, you're talking about the reach. How many people do we touch with this program? How many patients, how many providers, how many staff are involved in this program? And thinking about whether the EBIs were implemented with fidelity. So research shows that most evidence-based interventions, when they are leveled up, you find that some of them don't make it. And the failure usually is associated with how the EBI was implemented, and not really that there was not enough evidence for the evidence-based intervention. So fidelity is very important. And when you think about that, you think about your workflow processes. So what are you doing? What steps are you missing? What are the gaps in those processes? How you are navigating maybe the patient from when they come into the clinic and maybe when they get the screening. they complete the screening. So the next question, whether we implemented the EBS that we implement will be sustainable after the resources are gone, maybe not resources are gone, but after the funding goes for the program. We want to ensure that some of these activities will still be there after the funding is over, and that will be a good mark of our successful program. So how are we going to do this? We'll have interviews and hopefully at the end of the program, follow up with some of the clinics to see how they're doing. Maybe 6 months down the line, hopefully they're maintaining an upward trajectory and still have the EBIs in place. And the last question that we're looking at is whether what was the level of engagement with partner clinics? So engagement can be in different forms. For example, right here in TeleECHO, this is a form of engagement. And so we collect data through this TeleECHO session. So we have surveys, but we also have something called an engagement tracking log. And that's when we ask our clinic liaisons, we also ask our implementation team and our medical directors who go out and talk to the clinics when they have any on-site visits or any major virtual visits that they conduct that result in major decisions. We ask them to add that in the engagement tracking log. Next slide, please. So what methods do you use to collect data? So for this program, we use a mixed methods approach. We collect both quantitative and qualitative data. For the quantitative data, we have a CDC approved baseline readiness assessment. So we have to know how clinics are doing before we implement we start engaging them with GCRCCP activities. The baseline assessment has about 300 items. And a lot of that information really informs us on the EBI processes, of course, the demographic of the populations for the clinics are serving and so on. So it's very informative. And then each year after enrollment, we have a CDC approved annual data form, and it has about 170 items. And some of these items are the ones that were asked at baseline. So that really helps us to know whether the clinic, how the clinic is doing over time. Next, we have program developed surveys, for example, the TeleECHO surveys that we send to you from time to time. And the next type of data that we use, as I mentioned, is the qualitative data. So the program tracking logs I mentioned, we have engagement log, technical assistant log, and dissemination log. And in these logs, we make sure that we put in notes and some of those notes are qualitative. For example, what was the purpose of the visit? And this information is very helpful. And then next, we have in-depth interviews, and these we plan to have a little bit later, and we'll talk about it at the end of the presentation. Next slide, please.
So now that we know the methods of how we collect data, it's important to know what data we collect. So we collect health system and clinic level data, also demographic data at those levels, baseline, annual, monthly screening rates, evidence-based interventions implemented at each clinic resources that can help improve evidence-based intervention implementation, return rates such as fit kit return rates, colonoscopy completion rates, and follow-up colonoscopy completion rates, patient navigation data, clinic workflow processes. We also, as Dr. Odhiambo spoke on, engagement data such as the TeleECHO like we're on right now, and clinic engagement with the implementation team and medical directors. So now that we know what data we collect, it's important to know what the data tells us. Next slide, please. So here you can see for the health system and clinic level demographic data, this gives us a description of the health system or the clinic, and it shows the patient population characteristics, the number of providers, and the actual size of the health system and clinic. This can provide a good place to start when you're going to put in interventions. We have the baseline screening rates, which again, it shows where the clinic's at before there's any implementation of the activities, the EBIs. Annual screening rate, and this allows us to see the impact of those EBIs from the baseline data. And then along with that, we look at the monthly and annual screening rates, and this kind of will show the trajectory of where the clinic's going with their screening rates. And we also break that down into demographic subgroups, so we can identify if there's a certain subgroup that is not meeting the screening rate goals that we would like for them to, and we can see if there needs to be any further intervention or targeted efforts for that group. In return rates, this allows us to see how well the clinic is able to have their patients complete screenings, whether it's sending in their fit kits or simply showing up for their colonoscopy appointments or doing their follow-up colonoscopies. And then with patient navigation, this allows us to see patients that have completed screenings through patient navigation, and it shows what kind of screening they use, if CDC funds were used for the screening, and what were the results of the screening. It's really important for us to see if we are actually catching cancer cases with these screenings. And then lastly, we look at the clinic workflow process. This just shows the day-to-day screening process, allows us to see how efficient and effective each clinic's doing. We can identify gaps or any areas of improvement that needs to be made, and it also gives the opportunity to place emphasis on fidelity. Next slide, please.
So now we want to talk about how we use this data. It's important for us to put it to work. So the very first thing is we want to assess whether we are meeting the goals that we set out to ourselves. And as we said before, we want to ensure at least the clinics get to 60% CRC screening rates and maintain that. And also that is the goal set by CDC, but internally we would like clinics to do better, and 80% is the word, the number that everyone would like us to be. So we want to assess whether we are meeting our goals. And secondly, we'd like to use the data to make data-driven decisions. So when you think about even when clinics were enrolled, the CDC had criteria, and the number one criteria is that we have to enroll clinics that have a screening rate below 60%. So from the get-go, data has been determining the clinics we are including, and also it helps us with the day-to-day improvement of processes. Third, we do use the data to develop clinic implementation plan summaries. And so using the baseline data we collect, we are required by CDC to put a plan together for which EBIs are going to be implemented in which each specific clinic. All the clinics are different to some extent. And so based on the resources that they have and the adjustments that they can make, especially thinking about EHR capabilities, we come up with a plan for them. So the ideal situation is for us to have all EBIs implemented successfully in all the clinics. And this might be a challenge. So each plan for each clinic is unique. And so we have to develop a plan for them based on the baseline data we collect. And next, we share findings with stakeholders during clinic visits and make recommendations. So for example, looking at the summaries and data visualizations, we have a report on the right-hand side that is specific to one clinic. So this is a one-pager report, and Christopher will tell us a little bit about it later. And then we have a system report that is telling us the snapshot of one health system. So using this data, we can make recommendations on where we think efforts need to be intensified. Next, we'll use some of the data to encourage efforts. So for example, when you look at the trends over time and we see a trajectory going up, when somebody gets that information, they might be more motivated to ensure that they continue to perform the activities that are leading to this upward trajectory. So it's important for people to be told they're doing a good job when they are, so we give credit where credit is due. So the data can help us to show us, to show people this, because it gives evidence of that for the most part. And we also use the data to summarize the data and disseminate our lessons learned, hoping that what we learned is going to help other people. And when we share that, other people can let us know feedback and also help us on other ways we can also improve our activities. So these are some of the ways we use our data. So if you think about any other ways that you use your data in your clinic, you can let us know. And Christopher, you can talk a little bit more about the one.
Right. So the page on the far right, you can see the trends over the last 6 months. That was the end of 2022, and it's important to see that when it's broken down like this, you can see it by demographic or insured, uninsured, and doing it monthly gives us the opportunity to see, okay, one of these, let's say the uninsured group, they're starting to see a decrease in screenings. This gives us, it's close to a real-time way to see it and say, okay, something's not going the way we want it to. So we can talk to clinic liaisons, and it's just a direct link to, they can find out from all the providers, okay, this is what's happening. Do you know what might be causing this? And allow us to do a more targeted intervention at that time. So we just think that's really important.
Yes, and as you mentioned, those trends being monthly, it ensures that we can intervene earlier. If we are waiting for only the baseline and the annual data that we submit to CDC, we are unable to see the problem of like while the problem like over time. So having this monthly, tracking the monthly data ensures that we're able to make changes earlier and intervene earlier. Next slide, please. So next, as I mentioned, we also use qualitative data, and we want you to tell us about your experiences with GCRCCP. So we are planning qualitative data collection, and we're inviting GCRCCP stakeholders. We're talking about providers and staff for interviews. And the interviews will be about 30 minutes long, and we'll be very flexible with schedules, working towards eliminating structural barriers. So if you have time over lunch hour or after 5 p.m., we will be happy to talk to you so you can tell us about how GCRCCP is affecting your activities at the clinic. We're working with the liaisons to reach out, and we'll be scheduling the interviews sometime in April. And just as a final note, the findings we get from the qualitative interviews will make sure that it will be summarized and themes identified. And so no specific information from one person will be highlighted. So we are planning on this, and we hope we'll be able to participate in this data collection, because we really want to hear about your experiences. Next slide, please. So now thinking about all the information that we get when you think about data, specifically for this program, the challenges for the data collection haven't been much. When we think about it, the only one we can talk about is COVID-19. It delayed some of the onboarding of clinics, and also that delayed us gathering the baseline data. But besides that, I think everything was okay in acquiring the data. However, thinking about the accuracy of the data is also important. So we do collect the monthly rates, but sometimes on how the screenings are ordered, it might affect the accuracy of the data. So thinking about that, how do you use this monthly, the monthly rates? It allows us at least to see the trajectory, whether a clinic is doing well, is it going up or is it going down? And it allows us to intervene or make recommendation on when to intervene. And then next, depending on EHR capabilities, and that for that I will call out on Robbie, Amin, and Sable Fleming. Perhaps they can tell us a little bit about any issues that they experience with data collection.
Sure, yeah, I'll help you out. Well, just to, so I'm Robbie Amin, Dr. Amin. I'm the clinical liaison for the west side of the state for AAPHC and Blakely clinics. Basically, one thing why this is so important, I'll keep it quick because I know that we're running out of time here, but without data, unfortunately, we don't know where we're at. And that's one of the biggest things, is that for the provider in the clinics, yes, they want to do the best job, but unfortunately, they're only judged based on their numbers. So that's where we come in, trying to give them their accurate data, get workflows set up for them, and then also go back to the data team, Lorianne and her team, and say, look, these are issues that we're running into, and this is why we can't get accurate data. An example of a challenge that we run into, a couple of them actually, one is that labs, for instance, in our system, they're cleaned out. So for instance, one of the requirements we like to track is the fit return rate. So for a fit test, how many are coming back that we're actually ordering? So it sounds easy to do, but it's actually pretty hard, because if a test doesn't get done, then it gets deleted out of the system. And so we don't know that it hasn't been done. We only know the ones that got back. So that's one of the challenges for the return rate. Another one is that, and I'm sure a lot of providers on here are frustrated about, is that these things are multi-month processes, especially for a colonoscopy. You order it 1 month, then the GI consult will be a month after that, and then the month after that, you'll actually have the colonoscopy. So I know we've had this discussion within GCCRP several times about dissemination of data and getting it out. And providers don't like to see that the numbers aren't changing every month. Sometimes it'll go down because fit tests will time out and you're waiting on colonoscopy to be done. So that's some challenges that we're facing. And despite that, we still like to give the numbers monthly, because kind of where you're at and how many you're giving out and things like that. And eventually the needle will catch up. And so there'll be a big bump after a certain time. But these are some of the challenges that we run into on a daily basis. The rest could be a whole case study in itself, but I'll leave it at Sable if you want to add anything. Otherwise, give it back to Lorianne and your team.
Yeah, so I'm Sable. I am clinically a liaison for the East Side. We pretty much have had some of the same problems that Robbie has. I do know 2 specific problems that we ran into is we order a HemoSure in future labs. So when the patient actually sends the lab back, it gets pulled in then. So it's almost like it was ordered at that date. So the return rates doesn't quite work well for us. And then another thing we have is the colonoscopy referrals. So most of ours get referred out to general surgery. So we can't really track exactly how many patients were referred for a colonoscopy, which is what I'm running into right now with getting our numbers for last year. That's about it.
Thank you very much, Sable and Robbie. We can have Kush so we can continue.
Sure. Yeah, thank you guys for that interesting insight into what you guys do with the important work with collecting data. I've been going around to the clinics and presenting that really nice infographic that you guys have created. So hopefully providers that are on the call can kind of better understand what that infographic means and how to interpret that and how to use that in your practice to improve patient care and increase the number of patients screened, because that's ultimately what this is about, is we just want to make sure our patients get screened. So the key the key learning point for this Project ECHO is from Dr. Jones with starting messaging early about colorectal cancer. So of course, at first you start with talking about prevention, then you talk about family history, and then then of course at 45, that's the latest. That's the end point, as he calls it. And I think that was a really nice way of putting it, and a really great, insightful message for everybody. So I'm going to pass it back to Lorianne. She's going to talk about CMEs and conclude the presentation. Oh, Dr. Jones has his hand raised. Yes, sir.
Yeah. Hey, Coach, I just wanted to make sure too that really talk to your folks about signs and symptoms of rectal and colon cancer, the young folks, bleeding, change in bowel habits, rectal pain, because that's how they present. 60% of people with young colon cancer have no family history. They only present with symptoms, and because it's mainly a left-sided disease, they'll tend to have anorectal symptoms like bleeding, change in bowel habits, urgency, etc. So, teach them about it, and then when they have them, take them seriously.
Awesome. Thank you, Dr. Jones. That was an important reminder. So coming then back to Lorianne, she'll go ahead and conclude the presentation.
Okay, so to claim CME credit, please follow the link posted in the chat or scan the QR code. Thank you, Dr. Desai, for leading us through the presentation. And thank you, Dr. Whitney Jones and our team for the presentation. And thank you all who offered comments and ask questions. So as we always do moving forward, we're asking for case presenters. So if you would like to present any case from your clinic or any work that you're doing related to CRC, feel free to reach out to us at au_CRC screening@augusta.edu, and we'll be able to make arrangements with you. Our next session will be the first Wednesday of the month, next month, Wednesday, April 5th. We will share the flyer with information within 2 weeks. And we want to thank you so much for attending. And remember to wear blue on this Friday, March 3rd, for Dress in Blue Day to raise awareness on colorectal cancer. And just remember the whole of March is National Colorectal Cancer Awareness Month. And please, do take pictures when you wear blue, and anything that you're doing in terms of promoting CRC screening this month, take pictures and you can share them with us at our email. And just making sure that we're doing this collaborative and we're all on the same page, and making sure that people who need to get the message, get the message. So please feel free to leave at any time. Thank you so much for attending.